Hello, and welcome to the Royal College of Pathologists Guideline Implementation webinar series. My name is Peter Johnston, and I'm the Vice President at the College for Workforce and Corporate Engagement. I'm delighted to be hosting this webinar today, where we have leading experts and authors for the latest dataset for the histopathological reporting of carcinomas of the nasal cavity and paranasal sinuses. The authors will be clarifying some aspects of the guidelines with you that may be difficult for implementation, and they'll also be providing some tips and help with dealing with difficult areas and practical tips for clinical scenarios. And they'll be here to answer your questions. I'm pleased to introduce to you today's speakers. They are Dr. Amrita Jay and Dr. Matt Lofthouse and Professor Keith Hunter. Just before we start the webinar, I'd like to remind you that the presentation will last approximately 15 minutes, and then there'll be 20 minutes for questions and answers at the end. All participants will be muted, and so if you want to ask a question, please do so using the Q&A function, which is just to the right of center at the bottom of the screen. And you submit your questions that way, and we will take them and ask the presenters for you. So without further ado, I'd like to ask to begin this session on the dataset for histopathological reporting of carcinomas of the nasal cavity and paranasal sinuses. And Dr. Amrita Jay is going to take you through her presentation. Thank you very much, Amrita.
Thank you, Professor Johnston, for the introduction. I'm joined by my co-authors, Dr. Matt Lofthouse and Professor Keith Hunter, and together we will take you through some of the key points in this current data set. Before we start, we would like to acknowledge Professor Tim Halliwell, who provided us with immense guidance and help throughout the preparation of this data set. So the current data set was published on the RCPath website in Feb 2025, whereas the previous data set was about 12 years ago in 2013, and that was authored by Professor Tim Halliwell and Dr. Julia Volker. So we do have quite a lot of developments in that 12-year period. So we have updated some of our references up to June 2024. So the data set is based on all the core and non-core data items of the ICCR 2024 data set that are incorporated into the current RCPath data set. For certain data set items, we have provided some additional comments where we felt it was necessary. But what we have in this RCPath data set, which is different from ICCR, is we have updated the literature, and there is a summary on all the specific tumor types you can find in the sinonasal region. And we do have quite a few unusual entities in this particular anatomic site. So the tumor subtyping is based on the current WHO 5th edition sinonasal tumors, and the staging is as per the TNM8 UICC. So amongst the dataset items, the only non-core data item in the sinonasal region is the tumor size. All the others are in the core data, and the ancillary studies are somewhere between core and non-core, and we will discuss that in a bit more detail. So the initial three data items should be ideally provided by the clinicians, but we should make an attempt to get that information if they don't do that. That's the previous therapy, the operative procedure, and the specimen submitted. The tumor site and laterality obviously is usually provided, but that's important as well. And then we have the tumor type, tumor grade, and extent of invasion, which are quite important for sinonasal region because the tumor staging basically depends on the extent of invasion, and the grade of the tumor and the behavior depends on the tumor type. Other parameters like lymphovascular invasion, perineal invasion, there's not much clear evidence on the impact, but they do say that perineal invasion, if present, is more likely to result in involved margins in the tumor resection. So the first three items of core data, as I said before, the previous therapy, operative procedure, and specimens submitted should be provided ideally in the clinical, the resection request form. So the previous therapy, some of these cases, for example, undifferentiated carcinomas may have a neoadjuvant chemoradiotherapy, in most cases to shrink the size of the tumor. So if you do have resections for that, we have to evaluate whether there's a response to the therapy, or whether, and we don't necessarily need to quantify it. It's not currently considered mandatory, but we should have a note on what the response is and what type of response. That may dictate future management post-resection. And the operative procedures are quite variable. We do tend to have a lot of endoscopic resections in the sinonasal region, but we can also have en bloc resections such as craniofacial resections and mucoperiosteal excisions. And these resection specimens should be well orientated by the surgeon and all the critical margins marked. And obviously we do take photographs and radiographs for all our head and neck specimens. But it's especially important in this region because we have to identify the different bony walls of these sinuses and ensure we sample tumor tissue and the background tissue in all the different bony walls of these the sinonasal region. And we should have the annotated diagrams of these specimens available within the laboratory, and they should be available both for internal and external review. And one of the important additions to the data set is we need to specify the ideal block for molecular testing. And this should ideally be a non-decalcified block, and it should have a reasonable volume of a viable tumor. So the fourth and fifth dataset items that are core are the tumor site and laterality. And the tumor site, again, is really important because the staging system varies. We have two different staging systems. One is for the maxillary sinus, and the other staging system for the sinus is ethmoid and nasal. And so it's really important to know the epicenter of the tumor. Now, I know we do get large tumors which will involve multiple sites. So it may be useful to correlate with radiological findings, especially the older radiographs as well, to identify, if possible, to identify. But if not, mention all the sites that are involved by the tumor. And the other importance of tumor site is there is a prognostic importance, especially in regions like the maxillary sinus. We all know that the posterior superior part, the tumors involving that region, may be much more aggressive than the anterior inferior parts. And that's due to the proximity to vital structures such as the orbit and the cranial base for tumors involving the posterior superior region. So it's quite important for us to know where the tumor site is. And then obviously for diagnostically, some tumors such as neuroendocrine tumors have predilection for the ethmoid regions. So it's quite good to know where the tumor originated. One of the really important data items in the sinonasal cancers is the tumor type. So this is a table of the WHO 5th edition, which gives all the new tumor types. We do have quite a few new ones. So in addition to the conventional keratinizing SCC, we have the non-keratinizing SCC, which is always there in the previous data set. But in addition to that, we have all the kind of undifferentiated or poorly differentiated tumors, such as a nut carcinoma, the undifferentiated carcinoma, lymphoepithelial carcinoma, the Swiss-Nif complex deficient sinonasal carcinoma, the very rare teratocarcinosarcoma, and the HPV-related multiphenotypic sinonasal carcinomas. In addition to that, we do have neuroendocrine carcinomas. Majority of the neuroendocrine carcinomas in the sinonasal region are going to be like poorly differentiated ones, usually small cell or large cell. You can also have the rare carcinoma mixed with the neuroendocrine carcinoma. The neuroendocrine tumors as such are extremely rare in the sinonasal region. We also have adenocarcinomas, both the salivary and non-salivary types, and this was similar to what we had in 2013. We have the intestinal type and non-intestinal type, which are the non-salivary types. Also included in this data set is olfactory neuroblastoma. So in addition to carcinomas, we can also use this data set for olfactory neuroblastoma. So the additional feature of this data set is we have included an updated summary on all these specific tumor types, which should be useful for reference. the tumor grade, and this again, if you go back to the tumor subtype, we don't have specific grading systems for all the tumors. So for the keratinizing SCC, we can follow the usual grading system of well, moderate, and poorly differentiated. But for the other tumors, basically identifying a tumor as a nut carcinoma indicates this is most likely going to be very aggressive. Majority of these cases of nut carcinomas are very aggressive. Similarly, the SWE/SNF complex deficient carcinomas, there is no specific grading system for this, but majority of these tumors tend to be aggressive as well. Some of the other tumors, such as the multiphenotypic sinonasal carcinomas, which are usually caused by HPV type 33, but also a few by HPV 16 and 18. So these are usually indolent, but you can have high-grade areas in this as well. So again, we go back to the importance of tumor subtyping for grade of the tumor as well. The extent of invasion of tumors extremely important in the sinonasal region, because the tumor stage depends on the tumor location and its extent across the different bony walls. So we have to sample the tumor in such a way that we're able to convey the message to the clinician that the tumor has invaded the posterior wall of the macular sinus or the medial wall or the superior wall, etc. And because it's a complex anatomical site, many of the specimens are quite friable. And so extreme care should be taken in identifying tumor invasion across the different bony walls. And this is one tumor that is not staged based on the tumor size. So, and going back to the type of specimen submitted, it's almost impossible to measure the accurate maximum tumor dimension, especially in endoscopic resections, which are actually multiple specimens with some labeled as a main tumor and the others labeled as probably margins from adjacent sites. You may be able to measure maximum dimension in an en bloc resection, but again, it doesn't dictate the staging of the tumor. Some of the items that we don't have much evidence for in the sinonasal region is lymphovascular and perineural. So we do have to identify lymphovascular and say if it is present, and it can either be intratumoral or extratumoral. Similarly, perineural invasion. They do say that tumors with perineural invasion are more likely to have positive margins. But again, there's not enough evidence of that as compared to other sites such as oral cavity cancers, but we still need to mention it, and it is included as a core data item. Excision margin status is important, and carcinoma in situ at the margin is considered a positive margin. Now, in terms of assessing margins in sinonasal cancers, for endoscopic resections, you usually get multiple specimens. You get specimens labeled as a tumor, where you know the tumor is going to be at all the edges in any case. So the separate specimens sent are usually going to be some of your excision margins. So you can only say whether there's tumor in those specimens. So you may say it's positive or negative. So that you can't really measure the tumor to the margins in those specimens. But you can do this in en bloc resections and craniofacial resections. So there is no real definite what is considered as excised, but definitely we usually consider 5 millimeter, over 5 millimeters excised. Now, in terms of precursor lesions, identifying dysplasia in sinonasal tumors can be quite difficult. A lot of the time, it's actually the tumor colonizing surface epithelium. But it's really important to identify precursor lesions such as sinonasal papillomas, because we do know that inverted papillomas and some oncocytic papillomas, you can have a tendency to malignant transformation. The other feature that you may be able to identify is adjacent sites to intestinal type adenocarcinoma. You may be able to see metaplastic changes. So it's considered a core data item to mention if you can find that. So here's where we are at the ancillary studies. So the ICCR data set has included some of these entities as core. So we have kind of incorporated the same entities as core and non-core. But there is a caveat here. So they've said like parts of these are deemed core, but we can temporarily downgrade them to non-core if resources are not available. So what ICCR and we have followed is all the undifferentiated tumors. So if you have definite squamous differentiation, we don't need to do any immunohistochemistry. If you don't have definite evidence of squamous differentiation, for example, sinus undifferentiated carcinoma, or something that resembles a nut with probably limited keratinization, or there are some neuroendocrine features like trabecular arrangement or some nuclear features of neuroendocrine differentiation, then it's really important to identify that with specific immunohistochemistry. And that's what's, but obviously even these entities, it may not always be possible to get a very specific neuroendocrine marker to identify them, for example, INSM1. And so I think you should make every attempt to try and identify it. Some of the entities that are considered non-core currently may change in future. For example, they do say HPV, and we have kind of introduced the same feature that you don't actually have to identify HPV positivity. So it is considered a non-core in the current data set. Similarly with intestinal type adenocarcinomas and teratocarcinosarcoma, but some of these things can change in future. So the summary of changes compared to the 2013 data set, and again, like I said, it's mainly the tumor subtype. The histological type of carcinoma in the 2013 data set basically applies to the conventional squamous cell carcinoma and its subtypes, being based on morphology, the papillary, verrucous, basaloid, adenosquamous, acantholytic, and spindle cell. So currently we do have a completely different setup of non-keratinizing or undifferentiated tumors with specific either gene fusions or SMARC B1 negative, SMARC A4 negative tumors. So that's completely new in the current data set. The second item that's different is tumor size was considered a core item in the 2013 data set, although it did not determine staging. And this was only done just for comparison for imaging. So the current data set, in addition to the emphasis on tumor types and subtypes, do recommend to try access ancillary studies to subtype the tumors more accurately. We also have an updated summary on these unusual tumor types that can involve the sinonasal region. And as for all of the head and neck data sets, we've incorporated the WHO 5th edition classification of sinonasal tumors, and following the UICC TNM8 and the ICCR dataset, together with an updated literature review over the 12 years. So that's just a description of the current dataset. So what do we need to look forward to? So we do know that the TNM9 has been published. So we hope to implement that in 2026. The changes in the sinonasal carcinoma staging are minimal. There's no change in the staging for sinonasal carcinomas. However, the minor salivary gland carcinomas affecting the sinonasal region should be staged similar to the major salivary gland tumors. That's the only change we have in the sinonasal region, which we should start doing from 2026. This paper from 2024 by James Lewis and team and Sitala and team do suggest that there is good evidence that HPV detection in sinonasal SCC may be a biomarker for improved survival. So they have recommended doing routine HPV testing in sinonasal SCC. And the testing method they've suggested is by RNA-ish. So we need to detect transcriptionally active high-risk HPV using RNA-ish. And the P16 can be used as a screening tool before we do the specific RNA-ish. And for P16 to be considered positive, it is similar to the oropharyngeal P16 positive tumors. We should have at least 70% nuclear and cytoplasmic expression with moderate to strong intensity. So that's something should be incorporated in future. And then obviously we come to numerous articles on sinonasal tumor types, which is, I mean, each day you're going to get new fusions being detected in sinonasal tumors. So there's this, whether we should classify these sinonasal tumors using a molecular-based approach or based on etiology. And this is a classification, again, by James Lewis and Faden and team. And they have subclassified these tumors based on etiology, whether it's virus associated, such as HPV type and EBER type tumors, or if it is based on EGFR or KRAS alterations. For example, those SCCs arising from inverted or oncocytic sinonasal papillomas. And then you have the poorly differentiated or undifferentiated tumors, which have alterations such as nut carcinoma. Okay, so this slide is again based on the molecularly defined sinasal malignancies. So Skalova and team have indicated that you can have immunohistochemical markers for the specific genetic alterations for tumors such as DEC after fusion carcinomas, the nut carcinoma, the IDH2 mutated carcinomas, and the SNP deficient carcinomas. So, for example, for DEC-AF2, there is a immunohistochemical stain for AF2, and NOT we already have, and there is an immuno for IDH2. And for SNP, you can use INI1 and BRG1. So the absence of those immunomarkers will indicate these are the SNP deficient tumors. So there is something we can use if you don't have access to genomics in future. And so this slide is an interesting one, which I picked up because it says that role of pathology is important because we're continuously trying to refine the tumor classification. So this is really important for us to drive advances in patient care. And it also says, basically it says pathologists are quite ahead of the clinical management algorithms to subtype cancers. But it's really important in the sinonasal region because this is a unique region where you have many unusual tumors, and it's quite challenging to have clinical trials due to the rarity of the tumors. So they do suggest trying to group these tumors based on their shared molecular alteration. So they can develop some management algorithms. So it again highlights the importance of trying to subtype the sinonasal tumors, especially the undifferentiated carcinomas. And my final slide, there are some guidelines from the European Society of Medical Oncology, where they do again highlight the importance of tumor subtyping because the tumor behavior depends on the histology of the tumor and for prognostication as well. So because the tumors are rare, it's quite important that they are managed by an expert multidisciplinary team, whoever, especially in a high volume center, and also try to refine the molecular subtype of the tumor. So basically, in a nutshell, the changes in the sinonasal data set is basically an emphasis on trying to subtype the tumor, which determines the grade of the management as well as the prognosis. And with that, I come to the end of my presentation. Thank you very much.
Thank you very much, Amrita. Just while you're while the audience is thinking, there is a question which I'll put in context. We look as if, you know, we've got a very much an evolving situation where the way in which we diagnose particularly undifferentiated tumors is changing, a lot of it relying on technology and molecular techniques. So the question really is around what do we do in practical terms? So do we test all of these undifferentiated carcinomas for a variety of different markers? And if so, do we have a strategy for going about how we would do that on a regular basis? Do you want to pick that one up, Amrita, or one of the others?
Well, I will start and then I'll let the others continue as well. I mean, for the poorly differentiated and undifferentiated tumors, you can have a panel of basic immunohistochemistry to do all the pancytokeratins. So you can do all the AE1, A3, MNF116, CAM 5.2, and then take it from there with P63, P40. And again, it depends on the morphology. If it's showing absolutely no glandular differentiation, absolutely no keratinization. But if you do have certain hints, if it's showing abrupt keratinization, we can add in a NUT antibody, still keeping it to the immunohistochemistry if that is available in-house. If it is, for example, if it's a papillomatous lesion, I guess to identify something like a DEC-AF2 carcinoma, you would need genomics, you would need to send for the fusion because no immunohistochemistry is going to help you. So it basically depends on the morphology of the tumor. If it's an undifferentiated round cell, you do the whole panel, including to exclude sarcomas, mesenchymal tumors. And once you know it's a carcinoma, based on if there's some keratin or some degree of glandular differentiation. Also, you need to remember to exclude the high-grade transformation in something like an adenoid cystic, solid variant of adenoid cystic. So that's where sometimes if there's a hint of a solid variant of or high-grade transformation adenoid cystic, you can actually send it for a FISH for MIB, which could be available in-house. But other than that, obviously, you would need to resort to genomics. And I will leave Keith and Matt to
Keith?
Sorry, Amrita, I lost the end of your sentence there. Yeah, so it has to be done fairly pragmatically. I mean, I think everybody who works in this area is really quite glad of the fact that we are now beginning to lose the bucket diagnosis of sinonasal undifferentiated carcinoma. And we're realizing that, in fact, there are a number of, unfortunately, molecularly defined entities which are contained in that. And that is also something which is going to change, I would judge, probably over certainly the next few years as more entities are identified. But this whole thing of does the molecular diagnostics keep up with what perhaps some of the larger groups in the States can do in terms of the sequencing of these tumors? We are always going to have a lag with that as well, I'm afraid. And I think we just have to become comfortable of working in an environment where the diagnostic criteria are always going to be moving. And so we've got this a snapshot, as you have indicated, at this time, which doesn't capture all of the entities which are perhaps even now defined in detail, but it will do so in future. So that's why I think webinars like this are very important, because even now we see where we have moved to from the time when we wrote the data set. And as you indicate, morphology is going to play a large part in refining some of the tests that we would use, but also there are some which are just undifferentiated, in which we do now have a large panel of tests, some of which are going to be available locally in the centres, others of which are going to be available regionally, and some actually may well be in very specialist centres. For example, the Marsden seems to have a panel of tests that are only really available there. And so you've got to be able to have your particular selection, depending on what you get from your clinical appearances in the patient and the age of the patient and so on, and the morphology that you have.
Yeah, thank you. That's very helpful, because I think, you know, the how we actually do stuff and when we know when to get additional help is important. There is a question about P16, and you know, there was an interesting comment about the relationship of P16 immunocytochemistry and the RNA-ish that followed, the relationship of those. And so the question is P16 alone enough to diagnose HPV-associated multiphenotypic sinonasal carcinoma, or do we need to have the MALPATH stuff behind that? Who wants to take that?
Matt? Do you? Oh.
Sure, yes. I mean, you do actually need HPV-specific testing to properly diagnose this entity. The P16 screen is not usually enough in sinonasal tumours. And the other point really to make on that is your HPV-specific testing does need to include HPV-33, which is the sort of most common type of HPV in this tumour. So HPV-specific testing is required to make the diagnosis.
Okay, that's helpful. Thank you very much. The number of questions coming in is relatively small, so I would hope that more people will be able to ask some questions, please. While we're waiting for that, oh, here we are. Here's one just immediately, which is moving over from HPV to to Epstein-Barr virus. So the question is EBER more important than HPV? So is Epstein-Barr virus more relevant to this context than HPV? Or what is the relationship between these two?
Well, with the two separate tumors, I mean, the EBV positive tumors are similar to the ones that are seen in the nasopharyngeal region. Then, I mean, some of these so-called lymphoepithelial carcinomas, they need not always be EBER positive, but a proportion are positive, and they do respond. I mean, there are not that many of these, majority of those are that have extended from the nasopharyngeal region, which is not quite far away. It's just literally around the corner. So, so they do respond to a different kind of management. So it is quite important to, and EBER is quite easily available, just like HPV in most centers. So it's important to identify that the two separate entities, two separate types of tumors.
Yeah, thank you. And again, just for my education, are a lot of these molecularly diagnosable tumors related to specific target therapies?
The answer to that is currently not at the moment.
Mm-hmm.
I guess the hope might be that they will be in time. But at the moment, they don't seem to map very well onto current. So we don't have a large amount of drug repurposing in this area at the moment.
Mm-hmm. Mm-hmm. Okay, thank you. So just carrying on, there's a response about the P16. So the question is, if P16 is negative by ICC, should we go ahead with HPV DNA testing so that we can make the appropriate diagnosis?
I mean, yes, that is what we have been doing with that sort of thing. So even similarly to like oropharynx tumors, even with some of them P16 negative, I am still sending them off for HPV specific testing, which I would argue is the sort of gold standard.
Yeah, thank you. So there's a question in about tumor staging now. There's been a couple of comments about Wang staging for squamous cell cancers. Basically somebody saying that the surgeons are using this. We just carry on in that staging question, and perhaps we can address the Wang staging in the answer too. But this is about if a tumor involves multiple sinuses and radiology doesn't help with determining where the primary site is, how is it possible under those circumstances to stage the tumor? Presumably you get the tumor size overall, but exactly where it's come from may be a bit more of a problem. How do we address that?
I think this is quite, this would not be unusual in the sinonasal region because the majority of them involve multiple sites. And I think obviously the ones that are more aggressive would be the ones which are more posterior. And I'm, like for example, for maxillary sinus involving the nasal and ethmoid. So I think this is an MDT decision basically, and I would probably stage it as a maxillary sinus, because they tend to be more aggressive, once they've involved the posterior parts. But you just need to mention all the sites that are involved and then use a staging system based on which is a maximum bulk. I think that would be my opinion, but I don't know what do you think, Keith and Matt?
I think you just have to be pragmatic about this because, as you said in your presentation, Amrita, there are some of these tumours of which it's just not possible. You know, we have patients very tragically are presenting with really very extensive tumours involving multiple sites. And so in that case, you're guided, I guess, perhaps to some extent by help from our radiologists who may well have some sort of clue about where this has started. But in many cases, it may actually not be possible. And there is a certain extent to which, yes, the staging does change a little bit between maxillary sinus and the rest of the nasal cavity and the ethmoid sinus. But once you get to large tumours, it really doesn't matter that much for these patients where it's maybe not going to be possible to do that. And then probably in these cases, the subtyping of the tumour and the diagnosis may well be more determinant of the clinical outcome than the nuances of staging between these two sites.
Thanks very much. There's a couple of questions in about olfactory neuroblastomas. So the question is about how we differentiate olfactory neuroblastomas from a high-grade or small cell neuroendocrine carcinoma. Would you like to take that?
Well, the thing is, that's going to be extremely difficult. And I know Matt would have something to say about that, because we do have an entity called olfactory carcinoma. So I didn't mention that, but that's going to, that's the several papers on that. So some of the olfactory neuroblastomas, which are considered very high grade and which expresses more, I would say more, there's no specific, for example, some of the pan-cytokeratin markers, olfactory neuroblastomas should not be expressing them so extensively, but we have in our collection several that have expressed some extensive cytokeratin, and those tend to be higher grade tumors, and they are thinking they are olfactory carcinomas, basically, if they are from the right region. So that should be an entity that will come through. There are several papers on that. So they're basically a subset of tumors. They're slightly different from the conventional olfactory neuroblastomas.
So I guess just think about it when you see those sorts of wild-looking things, and you want.
Matt,
I mean, I suppose sometimes you get a bit of help with sustentacular cells positive for S100, but that isn't always there. I suppose the other helpful thing is probably correlation with the radiology to see if the tumor is coming from the olfactory cleft or upper third of the septum sort of area. That sometimes could give you a bit of a steer.
Okay, thanks. We're coming back to HPV testing by one way or another, and there's an element of controversy, or is it controversy, about the use of P16. So there's also, so the first one is that whether we use P16 as a screening tool or not, if we're going to do the HPV by RNA, what's the point of doing the P16? And there's a further question along the same vein, which is asking what are we doing with HPV DNA as opposed to RNA, and what's the difference? Because availability, I guess, may be different. So, Keith?
I'll address that. I think the point being, I think a lot of the data that we know in detail in terms of the discordance of P16 and HPV status comes from the oropharynx. And there's still going to be an open question about exactly how that will translate across to what we find in other areas of the upper air digestive tract. We know that, for example, in the oral cavity, that P16 is nothing like as good a marker for HPV status as it is in the oropharynx. So everything I say in terms of sinonasal has got to be viewed in that kind of context. So nonetheless, but we do know in the oropharynx that we are finding tumours which are P16 negative, HPV positive, with classic-ish morphology. And we know also that we certainly do have some which are 16 positive and HPV negative. And that is something which is important in terms of prognosis for these patients. So nonetheless, I think that when you are in the stage when you're thinking about doing an HPV test and you've done your P16, and I would suggest that we do have to do these HPV testing. The method is interesting. There's a lot been said recently about the fact that people have been quite hard on the sensitivity and specificity of DNA in situ hybridization, despite the fact we have been using it for many years. And there's also a certain extent to which some of the IVD authorized diagnostics for that have become unavailable, which has actually also been a problem. And so we have been using DNA PCR. We have been sending out in the interim when we didn't have any in situ technique, and we are just about to implement RNA in situ hybridization in Liverpool. But that's not something that across the range of all sites that is going to be available. And so in that case, I think we have to know where things need to be sent. The oropharynx data set, which we are updating at the moment, is going to come with a more rigid requirement for HPV testing within that. When we'll have a look at that, and that'll obviously still have to go through the review period for that before that comes out. But nonetheless, I think we're at a stage where there is significant discordance. HPV testing, specific testing, is going to have to be done, but the method of that and how we actually implement that across all sites in the NHS is an open question.
Yeah, thank you. I think it is a problem, which links just with the final question, which is going to have to be quite quick, I guess. Is that, I mean, Keith, you mentioned stuff being sent to the Marsden for, because that's the only place that has it. And, we've discussed the technology that's available and not available. When is it that we should be sending stuff away in terms of dealing with these complex cases?
I guess that is a question of what the point of origin is to some extent, isn't it? Where does this come into the chain? And if it's coming from a district general hospital where there's an ENT department where there's not the regularity. A lot of this has got to do with volume and just getting your eye in for these things. And so I would say that in that circumstance, you're finding there that, in fact, you probably should have a fairly low threshold for sending them out, because in that way, you will get the help that you need, and hopefully it is as responsible as those who are getting them to try and feed back and hopefully then be able to educate some of those who are sending to us, so that hopefully when you see it the next time that we actually give a genuinely helpful report back. In terms of the kind of functioning within an MDT, that's a bit more difficult. And I think pathologists in the MDTs get different areas of comfort in relation to how they see and the volume of them that they see as well. It does, unfortunately, I guess to some extent, Amrita and Matt will probably agree that as the sort of specialist centres where we get high volume of these, that we are going to have a significant referral practice for the most difficult ones. And we just have to accept that that is the case. Okay, thank you very much. Well, I'm afraid that's all we've got time for today. So please be aware that the recording of today's webinar will be available, and that's including the question and answer session, on the RC Path website in a short while after it's been edited out. So any of your colleagues who weren't able to see it today, or if you want to review it, it will be available in the next week or so. The professional guidelines team from the college will also send out a brief survey, and we'd love to hear from you what you thought of today's webinar. So thank you to all the authors, Amrita, Matt and Keith, for their contribution to today and for writing the guidelines, because there's an awful lot of work goes in behind that, and to the team in the college for all the work that they've done to support this. Our next webinar is on the 16th of December, and it will cover some of the latest guidelines on the histopathological reporting of urinary collecting systems. You can find out more information about all of these on the college website and upcoming webinars. So I hope you have an enjoyable rest of the day. Thank you for your participation and have a good afternoon.